The novel oral anticoagulants have elicited a great deal of interest, and rightfully so. Most recently, we're talking about the topic of cardioversion and these novel oral anticoagulants. We now have data from ROCKET-AF, from the RELY trial, and now from ARISTOTLE. And we have a paper coming in the March 25th issue of JACC, and it looked at the effectiveness of apixaban for prevention of stroke in patients undergoing cardioversion for AF. And I am with Dr. Matthew Reynolds, who wrote the accompanying commentary on the new data from ARISTOTLE. Dr. Matthew Reynolds is cardiac electrophysiologist and director of the economics and quality of life research at HCRI, the Harvard Clinical Research Institute. Okay, we now have data from 3 trials. What is it teaching us?
Yeah, well, first of all, thanks for having me. You're absolutely right. So there were 3 major head-to-head trials of novel oral anticoagulants, direct thrombin inhibitors and factor Xa inhibitors, relative to warfarin, and all 3 of them, with this 3rd publication from Aristotle, have now reported on their experience with cardioversion. Each of the 3 studies examined either cardioversions. In one case, the ROCKET-AF publication also looked at AFib ablations, but all 3 of these studies reported stroke events, stroke and systemic embolism events within 30 days of cardioversions on patients treated either with warfarin or with the study drug. And the results are all consistent. In all 3 cases, the event rates were very low. In all 3 cases, there were less than the risk of stroke or systemic embolism within 30 days of a cardioversion was less than 1%, regardless of whether you were treated with warfarin or one of the newer agents. And in fact, in the Aristotle data in this particular publication, there were no stroke events or systemic emboli at 30 days with either warfarin or apixaban.
I mean, part of the article that you wrote, the subtitle is Reconfirming a 50-year-old Standard.
Yes.
And I think that's an important message right there.
Well, sure. You know, I think the point of the subtitle is that anticoagulation practices around cardioversion are well entrenched, are well established, and to some extent have always been empirical. So what was fun for me about writing the editorial is I went back and looked at, Bernie Lowndes' papers from the 1960s, and because I was trying to understand where did the standard come from, and where the standard came from is that when they started doing cardioversions, many of the patients, a large proportion of the patients, had rheumatic mitral valve disease. So the risk of thromboembolism in the setting of cardioversion from the very beginning was understood to be high, and so the protocol was developed with the very first cardioversion studies to give those patients 3 or 4 weeks of warfarin prior to performing the cardioversion. And that is a practice that has stood the test of time. It stuck. It wasn't subjected to a randomized trial, but it was established as safe, or at least safer than not doing it. And then in the 1990s, there were transesophageal echo studies that were performed where the ability to visualize thrombus in the left atrial appendage became available for the first time, and actually really validated that standard, that existing standard, was effective and had something to do with preventing thrombus formation in the left atrial appendage or dissolving pre-existing thrombi, so that we can have confidence that from the data that we have now that these new agents seem to be every bit as good as warfarin in the cardioversion setting. Within the trials themselves, because we didn't have a published experience in Aristotle specifically, the investigators were given the option to switch patients to warfarin, to open label warfarin, during the trial if a cardioversion was planned. Now, not that many patients in the trial had cardioversions. It was only about 500 patients out of the total sample. Even within the trial, 85% of the patients remained on their study drug when they underwent cardioversion. So not that many of the clinicians decided to switch drugs. And I think based on the published experience now, there doesn't seem to be much justification if a patient is on a novel oral anticoagulant and they're tolerating it well and they're adherent, there doesn't seem to be much justification for switching them just because they're having a cardioversion.
Any bottom line message that you want people to take away from this?
Just really that's the one, is that cardioversion appears to be equally safe with the new drugs compared to warfarin. There are some limitations in the data from the trials. Obviously these are very carefully managed patients in the clinical trials. Clinical trial patients often are a little bit healthier than some patients you might see in community practice. And the other limitation that's worth mentioning is in ARISTOTLE specifically, patients had been on their study drug an average of 6 months before the cardioversion. So for patients with very recently detected atrial fibrillation, we don't have the same kind of data. We don't know, the safety hasn't been as well established. But I certainly find the ARISTOTLE data reassuring, as well as the data from ROCKET and RELY on this issue.
And it's the ARISTOTLE data and the Matthew Reynolds commentary that accompanies that. Please check out the March 25th issue of JACC for those papers. For CardioSource World News, I'm Executive Editor Rick McGuire.